Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. Today, we will be covering the latest advances in artificial intelligence for oncology and the implications they will have in the clinic in 2026. To begin, with Anita Grigoriadis from King's College London, who discusses strategies to increase AI literacy for oncologists.
My talk about AI literacy for oncologists really focused on broad themes to capture the data, the models, and the governance structure. So how can we provide education to our clinicians, but to all our stakeholders, in the healthcare system, that help them to feel more comfortable, that AI, may not be a black box, that their data is safe, and the data and the AI models are not biased. Yeah, so one strategy could be potentially, to hire an algorithmic consultant that is the middleman between, our clinicians and those that build these algorithms. So somebody such as a pharmacist, for example, that would be able to, advise what AI tools could be used and then work with the clinicians on the use of these AI tools and interpret these results. Equally well, this algorithmic consultant, and this was a idea that was published by Barbara Haban recently, is that this algorithmic consultant could also be, a new workforce in a hospital that looks out for different AI tools and vets for them, assesses them, then, employs these tools in the clinic and then ensures that the tools are working, consistently as they should do.
Next up, we have Rosalind Picard from MIT Media Lab in Cambridge, Massachusetts, who comments on clinical trial-ready wearables versus consumer devices in medical research.
So an additional thought is one of the questions at the end of the meeting was, why go with a clinical trial-ready wearable versus a consumer-facing wearable? And there are some interesting things that look the same on the outside, but are usually different on the inside. And I think that's important to start educating people about. So, for example, both the consumer-facing and the clinical trial-facing will tell you that they'll give you pulse rate. Sometimes they'll say heart rate, but if they've gone through FDA, they'll say pulse rate because, you can still have a heartbeat and constriction here and cut off the pulse, right? So if it's measured on the wrist and it's clinical trial ready, it's probably going to say pulse rate. And then you want to look at, are they just saying they provide pulse rate, or have they gone through clinical validation and ideally clearance of an organization like FDA? Because so any consumer device can claim that they provide it. And, now people have shown, for example, putting that consumer device on a potato, and it shows the potato has a pulse rate of 60 to 70 beats per minute, right? So these are clearly not the quality that you want for medical. Now, some of the better known consumer companies have done nice validation of their heart rate, but when you ask them for their raw data, they won't give it. And one of the problems with that is most of them won't give it, was illustrated recently in a trial at Harvard University that J.P. Onella, the PI on the trial, blogged about. He was using very famous, most advertised brand smartwatch heart rate data and heart rate variability data. And it looked really good the first 6 months they downloaded. And then 6 months later, they had 12 months of data, and they decided to not just download the most recent 6 months, but just to, with the same button, re-download the whole 12 months of data. To their shock, the first 6 months of data no longer matched, even though it was the same period of time, the same data. We downloaded it before. We just re-downloaded it. It should be the same. Why did it change? Well, when they dug around, it turned out that the consumer company, which is not in the business of providing data, they just happened to be, allowing that at the time as a side thing, they had changed their algorithm and they no longer offered the same quality of interbeat interval data, which meant that one of the key measures JP Onella and team were using, the pulse rate variability, was now unable to be computed accurately for their study. So it literally sabotaged one of their endpoints because they were using a consumer device, and the consumer company is not, in their first and foremost business is selling devices, not data. So if you are doing especially a long-term study where companies are constantly changing things, it's important to do an arrangement up front with your provider of the data that they will give you the raw data or maintain, provide the same exact computational biomarker over the duration of your trial.
She also discusses the emerging use of wearable devices in oncology trials, particularly for monitoring sleep and stress changes.
Yes, it's new. They're just starting to be used in oncology trials. They're being used for, the ones I've seen so far, are being used for sleep and stress changes. In particular, the stress and anxiety measures are super interesting because a lot of patients experience nausea, and that's one of the terrible, side effects of the treatments. And to some extent, that's the treatment, but to some extent, and possibly in some cases a much larger extent, it's the anxiety of going in. They're tossing their cookies before they even go in because of the memories, and helping them see the data that, this really is an anxious response, and here's something you can do to support it. Sometimes gives them a sense of greater control and management, which is really helpful, right, when cancer is running through your body, right? Anything you can do to enhance a sense of patient self-efficacy that then results in them feeling better. And then when you feel better, you can manage everything else better. So when you go in for the treatment, you're less likely to be, very sick and needing somebody to talk to you for a long period of time. Or maybe you even need somebody to talk you into going back to the hospital, right? Or to the treatment center. So managing the patient stress and anxiety, I think, is an undervalued but great, contribution to improving their health. There's also improvements now in measuring lots of the other side effects. So the devices are being put in trials also for monitoring autonomic changes that relate to CRS, which is another new area. So that's very exciting.
Following on, Jana Lipkova from University of California, Irvine, highlights the growing role of AI in clinical practice, including the development of AI-based diagnostic tools that can provide more accurate diagnoses and stratify patients for treatment.
Okay, so we are starting to see the AI being used in clinical practice. Like we have AI-based diagnostic tools like Artera AI, which they have the diagnostic and prognostic model for the prostate cancer. So there are these new models that can provide more accurate diagnosis, stratify patients for the treatment based on the treatment response. And I guess we're going to see more of these models, not only make better predictions, but also to reduce the cost of healthcare. So we can have AI models that can provide like digital biomarkers that can replace expensive gene sequencing assays. So we can have reduced cost of treatment. We can better screen patients for the clinical trials. And the next direction would be where AI provide new insights, things that we don't do as pathologists or as clinicians, like how to say which patient should go to which therapy, to see how the patient's going to respond, to build the digital twins and see how the patient will behave under different types of therapies. And then we can pick the best one for him, like having this in silico trial for each specific patient. Okay. So another interesting or important direction with the AI is improving accuracy and safety of these AI models. Because now, as I mentioned, we have highly specialized models that do one thing and they do it very well, but we assume that this model always going to be performing on the type of data they will train. But in medicine, there is nothing regular. Every patient is different. There is a lot of variability. And we need these like guardrails that allow the model to make predictions when the data fit its domain expertise and abstain from predictions when it meets some new task or it's not sure or it cannot just make reliable predictions. So similar like pathologists or clinical fellows would do. If you are sure about the diagnosis, this is like a typical case, you make your sign-out case, you make the diagnosis. If you're not sure, you may go to the tumor board, you may order additional tests. So we want AI models to mimic this behavior, to admit when they cannot make reliable predictions, maybe request additional data, work with other models or other experts to make better prediction. So important point is increasing safety and accuracy of the AI model when we speak about the translation to clinical practice.
Finally, with Roberto Salgado from the MacCallum Cancer Centre in Melbourne, who presents findings from a retrospective analysis of the Phase 3 Affinity trial, comparing manual, digital, and AI-derived tumor-infiltrating lymphocyte scoring methods with prognostic predictive associations in HER2-positive breast cancer.
So the Affinity trial is a very important practice-changing study showing that if you combine two drugs that block the same molecule, HER2, versus just one drug that blocks HER2, that you have in the lymph node positive patients, or patients with cancer in the lymph nodes, you have an important benefit of the treatment. That's what the Affinity has shown. Now, it is also a bit of a controversial study. Why? Because the overall survival benefit is actually very minimal. So patients benefit good, but in terms of overall survival, do they live longer? It's actually a minor difference. And that's the reason why in some countries, the drugs are not reimbursed. So there is an urgent need to define markers that can identify those patients who may need this double blockade versus a single blockade. Okay? And we do know from a lot of work done by the TILS working group that the immune system is a very important variable in helping to inform, and that's an important notion, to inform clinicians and patients about what is the outcome for me and will my tumor respond to these treatments. So what have we done? We have analyzed the immune system, the TILS, manually. I did it, 5,000 patients, almost got me a divorce. We also analyzed the same cells using a computational method, but not based on artificial intelligence. And we have analyzed the same cells with a computational method based on artificial intelligence, which was a method developed by Case 45, a startup in London. What have we demonstrated, that's important for the community, is in terms of prognosis and prediction, both of them, manual as computational derived, AI versus non-derived, predict outcome and benefit to the treatment. But we have also shown that if you combine, and that's probably the way forward for AI in digital in pathology practices, if you combine the pathologist work with an AI metric that identifies spatial patterns of the immune system, which pathologists see but we cannot quantify, if you combine both of them, the outcome and the benefit of the treatment is slightly better. So this suggests that in daily practice, the pathologist will continue to have a very important role in identifying the basic biomarkers like the TILS. But AI can complement and provide very important information for our patients and clinicians about having and finding those patients that benefit more from the treatment and the outcome.
He also discusses how AI can identify high-risk lobular breast cancer patients in the TAILOR-X trial.
So one of the interesting things about the community where we reside, the scientific community, is that the TAILOR-X study, when it was first published many years ago, it didn't include histology. So we had no clue about these different histological phenotypes, whether they behave differently when they have the same genomic risk score. Now, what does this mean? We know that breast cancer is a family of diseases, but the two most important families within that big family are the ductal and the lobular phenotype. Okay. So what we did with the TILS working group, and this was a study that was coordinated and led by Joe Sparano, the PI of TAILOR-X, we have analyzed the 10,000 slides from all those patients to identify ductal versus lobular histology. And we did find that histology, as defined by the pathologist, is a very important prognostic variable. That means that if you are low genomic risk and you are ductal or lobular, if you have a ductal phenotype or a lobular phenotype, that those who have a lobular phenotype have a very bad outcome. They have at 15 years follow-up up to 5% lower overall survival compared to the ductal. And this is clinically important. Why? Because those patients today get the advice, because you are low genomic risk, we will not give you chemotherapy. We have shown that those patients with lobular phenotype, that they may actually benefit with more treatment because they are low genomic risk, but maybe clinically high risk. In addition to that, to make this diagnosis more precise, we have to combine the pathologist, just like in Affinity, with an AI assay that measures a specific genomic alteration, typically for lobular. And what have we shown is that in the very large majority of cases, pathologists are quite good at making diagnosis of lobular, but there were discordances, meaning it was not perfect. And AI could help us to reduce more this uncertainty of the histological diagnosis. So the combination of the pathologist with the AI was actually a very important prognostic variable and reassuring the pathologist that what they do already is qualitatively. And in addition to that, and that's the second element of AI within the TaylorX, a bit similar like Affinity, we did find that patients who had low genomic risk, that had this different histology, that if you add a metric of the immune system that we co-developed with Case 45, that we could even then identify more patients who were clinically high risk of recurrence. So combining histology by the pathologist plus AI, plus a metric of the immune system with AI, we were able to identify patients who currently today get the advice not to get chemotherapy, and that we believe, based on this evidence, thanks to AI, that those patients could benefit from more extensive treatment because they may be clinically high risk.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favourite podcast app, including Apple, Podbean and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.